Good afternoon, everyone. My name is Grace Suva, and I'm the moderator for today's Champions Information Sharing webinar. And I'd like to welcome you this afternoon for our guest speaker. So before we get started, just want to introduce again myself. I am the moderator. My name is Grace Suva, and I'm one of the managers on the implementation science team here at RNEO. And then we also have Andrea Stubbs, who is the project lead of the Best Practice Champions program. And if you have any technical questions behind the scenes, please feel free to email or message her in the chat box, and she'll get back to you and help you as best as she can. So just to let you know is that these webinars are means of supporting RNEO's best practice champions, as well as other healthcare providers who are interested in guideline implementation, evaluation, and sustainability. And so our speakers that we have selected are those who are actively involved in BPG implementation. And so today we have the pleasure of Tolleen Parkin, and she will present on the Lean strategy for skin and wound care. So before we get started, just want to keep a few things in mind. First is that we want to have these webinars be interactive and engaging. And so we do have a period for Q&A, about 10 to 50 minutes, depending on how long the presentation is. It's usually about 20, 25, it can be as much as 30 minutes. And so please feel free throughout the presentation or at the end of the presentation to write your comments or questions in the chat box. But please, when you type in your comments or questions, to address it to all panelists and attendees so that everyone can see them. So there's also the recorded webinar. We will be recording this webinar today, and it'll be archived and posted on the RNEO website for future viewing if there are colleagues who you know of who are not able to attend today. So if you participate in the webinar and I happen to read out any of your comments or questions, just please note that by doing that, you have implied consent to be recorded and to be posted on the RNEO website. So now it is my pleasure to introduce to you Tolleen Parkin. She is a registered nurse with 25 years of experience in a variety of clinical settings and managerial roles, 15 of those years which are in long-term care. She has a Master of Science and Healthcare Quality degree from Queen's University, and she is passionate about the utilization of quality tools to assist nurses in long-term care in improving outcomes for patients. So for those of you who are not familiar with BPSO, our Best Practice Spotlight organization, just in case myself or Tolleen will use that term. It stands for a program that RNEO runs called the Best Practice Spotlight Organization Program. And it's for healthcare as well as academic organizations, and they're selected through this request for proposal process to be able to implement as well as evaluate systematically RNEO's best practice guidelines. And so it's a partnership where the goal is to make a positive impact on patient care through evidence-based practice. And so these organizations enter into a formal agreement with RNEO for 3 years in order to implement anywhere from 3 to 5 best practice guidelines. So now that I've done introductions, I'm going to pass the presentation ball to Tolleen to start her presentation.
Sorry, I couldn't find the mute button there, Grace. Sorry about that. It disappeared off the bottom of my screen.
No worries.
Sorry, thank you very much. Now, I'm not sure if I'm seeing. Do you see the presentation? Because I don't.
No. So I will, let me just move this for you temporarily so that I can get to your presentation here. So do you see it now?
Yes, I do. Thank you.
Excellent.
I don't know if you want to see my face or not. Like, I can't make my video work, but that's okay.
Okay.
So thank you very much, everyone. I appreciate being asked to do this presentation. So I wanted to just share with those on the line just about a strategy that we had implemented at my home related to one of the best practice guidelines that we're working on, and sort of dovetailing some lean strategies into that work that we found quite successful. So we just kind of thought it'd be nice to share with people in the sector. I've lost it again. Just a moment. No, Grace, we might have to go to plan B. Oh, there we go. So today we wanted to just sort of talk about a little bit of the basics of Lean, and my apologies if people on the line are really familiar. I'm going to do an extremely high level sort of introduction to some of those tools that will help you understand what we implemented, particularly the Kanban technique within the sort of Lean toolbox, and how that process helped us improve our outcomes in our skin and wound best practice guideline and what that looked like. So that's kind of what we're going to talk about today. And we'll just, yeah, there we go. So just a very little bit about us. So I just thought it'd be kind of nice to see some fun pictures of our homes. So during Nurses Week, this is some of our team, and we had dressed up one day to entertain the residents as heroes. That's me to the right there. I was the COVID crusher that day, so we had a bit of fun. So Gateway Haven is a municipal home, not too large. We have 100 beds, and we're located in a beautiful, beautiful, gorgeous rural area on the Bruce Peninsula. So it's quite a pleasure to work with such a great team and such a wonderful place to be. So the best practice guideline that I'm speaking about today is the risk assessment and prevention of pressure ulcers. So just a little bit about where we started and where we were trying to get to. So, and we're still on this journey. I wouldn't say that we're complete with this BPG yet. We're still working through things, of course. I think it's always a continuous journey. But, you know, we really wanted to work on skin and wound, felt that this was an appropriate place to begin. And when we looked at things, we didn't struggle with all the recommendations in the BPG, but the one area that we did find challenging was actually completing the assessments as we needed to. So, you know, on admission, when residents are transferred, going back and forth to hospital, coming in from outside, if they've been out of the home for a couple of days at home or with their family or what have you, and those weekly evaluations of already identified skin issues. So we were just having trouble with timing. We just weren't doing that as well as we should, and recognizing that those timely assessments really help in the preventative piece from things getting worse, and be able to implement interventions in a timely fashion that would prevent any further deterioration and help with the healing process. So we struggled with that. So that's kind of where we started. And the traditional approach, is I'm sure everybody on the line is well aware, is that, you know, we set up our assessments in the TARS, whatever system you have. We happen to use Point Click Care, and I'm sure a lot of folks on the line use that particular software. So, you know, we set up the assessments in TARS. The assessment pops up and reminds the nurse that it's time to complete that assessment. And the nurse, of course, signs off once it's complete, and of course uses whatever assessment tool that you are using in your home. And we have a tool that we use in our software. And, you know, that's sort of the traditional approach. But we certainly found that, you know, we weren't doing that so well. And for a variety of reasons. And some of the reasons that we identified was, you know, the nurse would go to do it and the resident might be sleeping. They might be unavailable because they're perhaps at a program, or they're in some other part of the home doing something, or the nurse would get tied up and busy with something else and it would get missed. We would pass it on to the next shift, and the same sort of cycle would happen, and the assessment might actually get delayed that day, or even a little longer sometimes. So we really knew that we had to think outside the box to figure out what we could do to solve this problem. And so we kind of looked to some lean strategies for inspiration. So I'm going to just sort of pause there for a second and talk about Lean first, to give people a sense of what that is. So Lean is simply a strategy, a tool, a philosophy that is all about reducing waste in systems and processes. It's about trying to find better ways to do things and build better capacity. It's about preventing errors. It's a significant concept about reducing errors in order to improve workflow, to improve outcomes, to improve capacity of staff, all of those kinds of things. It's about finding ways to do things more efficiently, to take the extra pieces out of a process that actually waste time and don't add value. And it's about increasing capacity within our existing resources far more so than any concept about reducing resources. So it's never about removing staff or people or even money from the equation. It's about how do we save those processes or materials or time or resources so that we can utilize them in a more effective manner. And the way long-term care is today, I always say to the staff, we have to find ways to work smarter, not harder. It's so important because with the acuity of residents in our sector and in our industry and in healthcare in general, that's really tough, and we're expected to do more and more with no more resources. And so Lean is actually a really great way to try and really look objectively at how we do things to try and do that better. And I don't think I put it on the slide, but it's extremely important that we involve the people who do the work in that decision making. So this has to be a collaborative approach. It's not just, me at the top of the organization pushing something out and saying this is how I think it should be. It's really important that we involve the people who actually do the work. So it's very much about solving the right problem. Oftentimes when we look at problem solving, we jump to solutions before we've truly evaluated what the actual root cause is. So Lean really helps us do that. And it is, which is what I'm really going to show you today of what we did. It's about making work visual. And that's the tool that we ended up using mostly out of this Lean toolbox, is how do we make work visual so that everyone sees it, which helped us not miss it. And it's obviously very cyclical. So it's about seeking ways to constantly improve and reduce waste. And I could go on and on and on and on about that. So I won't do that. That's what we're here for today, but that's just a very quick highlight about what Lean is. And then just very quickly, because some of the terms that is used in Lean, very much born out of manufacturing. It started with W. Edwards Deming way back in, I don't know, the 40s or so. He's considered the father of total quality management in systems theory, and he took his theories to Japan and to the Toyota company, who really embraced what he had to teach them about going to the Gemba, which is the staff coming and having the power to help solve problems, and management going to the work floor to see what those issues were, and staff having the ability and the power and the authority to actually stop production when they saw waste or when they saw a problem, so that it could be addressed in the moment. And so that's where it started. And Toyota just was head and shoulders above their competition for many years back in the mid 50s, 60s, in there somewhere. So my point about this piece is that there's a lot of Japanese terms. So going to the Gemba, Kanban is a Japanese term, the Ishikawa diagram, those kinds of things. And it did start in manufacturing, and healthcare was kind of slow to get on board with the concepts in Lean, I think. We've been really embracing them over the last 15 years or so, I would say. But we're way behind where manufacturing or the air traffic industry is related to moving quality forward, but we certainly are at least jumping on the bandwagon now. So that's very good. Very quickly, these are just some of the tools. I'm sure you've heard some of these terms, but Lean uses these kinds of things to help identify issues, help identify processes, help us move forward. So value stream mapping, process mapping, those are two different but similar concepts, and they help an organization understand what the current state is, identify opportunities to streamline or make improvements and standardize and do things differently, so that you can create a new map that actually eliminates or removes waste from your system. Root cause analysis is huge. The fishbone, I'm sure most people have worked with that in the past, and that's one of the tools. And the 5 whys, which is sort of embedded in the fishbone. And the 5 whys is kind of what we did here. The 5S, which I love to pieces, it's a great tool to keep work standardized and organized. So it's basically you sort things out, you tidy them up, you clean them, you make it stabilized, I guess is the right term, and then you sustain that process. If you go into like an emerge department, you might often see that they've taped the floor to where the crash cart belongs, or where certain kinds of tools belong, and that's part of the 5S kind of concept, so that no one's running around looking for the crash cart when you really need it, because it always goes back to that one spot, and that's part of the 5S kind of concept. Six Sigma is connected with the Lean philosophy, and it's more the statistical analysis. Kaizen is again bringing staff together to help solve a problem. Again, it's meant to be very quick. It's not meant to be a committee for 17 years. It's meant to be, you know, a day, 2 days, 3 days, figure it out, do a process analysis, and come up with a solution and implement it. It's supposed to be fast. And Kanban, which is what I want to talk about today. So that's kind of very, 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 very fast, high level Lean. So I'm talking through that really quickly, sorry. So back to our problem with our skin assessment. So we just kind of look at the 5 whys. So that's sort of a very basic tool that helps us drill down to what the real issue is that's causing the problem, so that we don't leap to a solution that won't actually solve the problem. And I don't know if you've ever heard this story, and I'm not going to get it exactly right, but the Washington Monument a number of years ago, they were really struggling with the structure was actually deteriorating. The outside of the building was just deteriorating, and it was the strong chemicals that they were using, and so they tried all kinds of strategies to address that, and it just wasn't working. And there was because the birds were you know, leaving their waste on the monument, so that was a huge problem. They had to use all these strong chemicals to clean the monument, and so they went to all kinds of expense. I forget how much, like $2 million a year or something it cost to try and prevent this from happening. And when they really analyzed it, it came down to the birds were attracted by, I don't know, some other insect, which was attracted by gnats, the gnats were attracted by the light that was shining up on the monument at dusk. And by simply changing the time of day when the lights came on, which cost nothing, they solved the problem. So rather than throw all kinds of chemicals at the problem, just changing the lights was what was needed. So that's kind of an example of how the 5 whys kind of works. So here we have, you know, we just kind of looked at, well, what's our issue? So why are our assessments late? Well, the nurse didn't know it was due until it came up on the MAR. So she didn't have a real understanding until she's gone in to do that piece of her day, that who has to have an assessment and when. So up it pops on the MAR at whatever, 10 o'clock in the morning, and she'd go to do the task and the resident wouldn't be available. So, you know, why was this an issue? Well, you know, because we set them for 10 a.m. That's what we do. Why do we set them for 10 a.m.? Well, because, you know, it's set after the med pass and after other tasks are due, because it's convenient for the nurse at that time to put them on the TARS at that moment in time. Well, why do we do it that way? Well, because that's what we've always done. So in this case, we didn't really get to a 5th why, because really, because that's how we've always done it, isn't really a great answer. And it really isn't an answer as to what would be an appropriate way to do this process. So we had to say, well, is there a different way that we can think about this? I hope that makes sense. So that was our aha moment. We had to say, wow, we need to really think differently, and maybe that TAR system wasn't working for us. And so when we did that, we used the 5 whys with Lean, and then we turned to another concept with Lean to try and make assessments visible throughout the shift for the nurse, rather than just when they come up in the TARS. Rather than the nurse having to go in and check the TARS and go through the whole thing to figure out what do I need to be thinking about for what time today, or just waiting for it to come up, is there a way to make that visible in a simple way during the whole shift, and for all nurses, not just the nurse on shift today, to be aware of what needs to be done today and tomorrow and the next day. So we turn to Kanban. And so my little images here, the supply box there is actually kind of a 5S kind of a strategy, but it's a visual work. And again, I could talk all day about that stuff, but I've actually implemented in long-term care strategies that are similar to what hospitals use to manage supply and help you with your supply ordering. And a lot of it is very visual. It's about boxes like that you can see immediately. If the box is empty, you're out of that supply. And I'd be quite certain that behind those boxes, there's a second box that is actually, so you actually sort of have two supply cycles on hand at any given time. So when the one box is empty, you know you have to order it. Nobody has to count. Nobody has to go and look in any great detail. You can see, oh, this is what I have to order this week, and I won't run out because I've already got next week's supply on hand. So that's a sort of visual Kanban 5S kind of concept. I throw a traffic light up here because I think it really illustrates, this is my little brain, but I think it really illustrates the visual, the power of visualization, I guess is what I'm trying to say. We all know without really any great education or training, I mean, we always get educated when we go to driving school what red, green, and yellow mean, but all of us know that, right? We don't need signs that tell us when we see a stop sign, a traffic light. We know that red means stop, yellow means it's going to change to red soon and you better be careful, and green means it's okay to go. And we use those colors in all kinds of other ways in our society because it's so understood. It's so well understood and is very intuitive and instinctive. That's a visual system, right? And then the other little picture there is very much what a Kanban board looks like. Sticky notes and some sort of chart of some way that, for whatever the problem is that you're trying to work with, up on a board where everybody can see it. So I'm going to show you what we did at Gateway. So Kanban is just simply a way to make work or processes visible, and it's easily understood by all. So this is our board. So, and I know this is a bit small, I'm sorry. So basically what we did was in our med rooms, and not in a public area because resident names would be on here and some sort of issue around their skin. So we didn't put it where it could be really seen by the whole resident home area, but certainly for the nurses. So it happened to be located in our med rooms, but other types of Kanban boards could absolutely be located in more public areas. So we set up two boards actually. So two boards side by side in the med room. One is for the current week and one is for the following week. They're just by days of the week. That's what structure worked for this particular type of Kanban board. And we color-coded the different types of assessments. And I can't remember right off the top of my head, and I can't see it because it's kind of small, but the yellow would be the weekly assessments. I think pink was admissions. Blues was somebody who'd been out of the building for a period of time and needed to be reassessed. And green was for hospital admissions or readmissions. And so those sticky notes depicted those particular types of assessments. And when an assessment needed to be done, we simply put those sticky notes with the resident's name on the board under the day of the week that they needed to be done. And so for that week, and the same thing for the following week, because once, if today is Thursday, once we hit Thursday, then if we're looking at next Thursday, we need to have a place to put next Thursday's assessments on. So there had to be sort of 2 weeks at the same time up on the board. But and so when the nurse comes on duty, if she starts our nurses start at 6 o'clock, she can see immediately at 6 o'clock in the morning who the assessments are that she may need to do today and what type of assessment it is. She doesn't have to log into Point Click Care. She doesn't have to go through the TARS to figure that out. She can see immediately, because at the end of the day, the assessment might come up in the TARS for 10 a.m. It doesn't really matter what time of day that assessment got done as long as it gets done. So the time was arbitrary. And so by seeing it right away at 6 o'clock in the morning, she was better able to coordinate, he or she, I apologize to the men on the line, sorry. He or she was able to coordinate with the rest of the team for what that resident's activities and plans were for the day, so that they could do that assessment when it was most convenient for the resident. When was the resident waking up? You know, PSW, can you let me know when you know, Joe is going to be awake, or when he's getting ready for the day, and I'll come down and do his skin assessment before you finish getting him dressed. And then I can help you with that too while I'm in there. You know, that kind of thing. So when is he going to have his bath? You know, that kind of stuff. So we could really be able to do that work when it's more convenient for the resident, rather than, oh, at 10 o'clock, it's convenient for us now, but you know, we have to ask the PSW to stop what they're doing, have the resident come back to their room, get undressed in some way, depending on what thing we're trying to assess, what part of the body, and perhaps really inconvenience people. And that job took longer. So if we coordinated at the start, we can do a better job for both the resident, the PSWs, quite frankly, and of course the nurse. And the other piece is that any shift could do this as well. So if the night shift happened to have to be in to see the resident because they were restless and something happened and the resident's wide awake and they have to be in there doing something, that might be a good time to sort of get that assessment done as well. So all shifts could participate in the process. We haven't assigned them specifically just to days or evenings. It's understood that everybody is responsible, that those assessments need to be done today. So they're able to work with each other, and days gets done what they can. Sometimes nights is able to do something because something happened on their shift. And then evenings finishes up, kind of thing. And it's worked extremely well. And as I said, really to the betterment of residents. We're less disruptive to the residents. And simultaneously, the staff have found that they actually do a better job of the process. They're able to do it at times in moments that they actually have themselves better time to do it, less rushed, and they themselves have found that it works pretty well. So I think that covers the whole description of what happened, what the process was. And then as they finish, so as you complete the task, you move the sticky, and way up in the top corner there on the right-hand side, there's a little done box. And so as the assessments are completed for the week, the little sticky goes up into that box. And that's actually a psychological thing too, because staff see those stickies piling up in the done area, and everyone sort of has a good feeling. The team feels good about themselves and their teamwork and their collaboration, that we got all of that work, that really important work was accomplished, and accomplished on time. We audited, of course, to make sure that it does happen, but we have found that, you know, that's not been as big a factor for us at all. So the one comment I do make, of course, is that this is outside of the clinical chart. Obviously, they still are doing a physical assessment and charting on that, and they're still implementing interventions and doing all of those pieces that we need to do in the clinical record. But so the stickies are slightly an extra task, but it has improved efficiency tremendously. So I don't see it as a hugely extra thing. We started this process 15 months ago or 14 months ago, something like that. And immediately we had 100% compliance. So we were doing our assessments on time, like as soon as we put these boards into place. We went from not on time to 100% on time, and it's been totally sustainable. We have not had to do hardly any follow-up with the team to keep making sure that it's done. But don't get me wrong, there'll always be a little blip, or maybe there was an assessment late, but you know, very occasionally it's not a significant issue at all. So we have found it's quite successful that way. So oops, I lost it, sorry. Let me try that again. Do it. There we go. Sorry. So I think I'm almost done. So we certainly found we were successful, like almost like immediately as soon as we put those boards into place. Been able to sustain it for more than a year without really any effort by the DOC or our clinical care coordinator to remind staff to complete their assessments. It's on the board. Everyone sees it. We see the done stickies, and you know, the stickies being moved up into the done box. And everyone has a sense of accomplishment and of pride, I think, in making sure those things happen. And certainly, I think a really positive consequence of doing that work is that as I said, the quality of the assessment I think is better, and absolutely the interventions are better. So it's more thoughtful, it's not rushed, we're really able to think it through, go to the care plan, talk to other team members. There's a real ability to plan that well, and that's happened extremely well, I think. So, our process indicator through this process was, completing the number of assessments that we complete on time, and of course the goal was 100%. And the outcome indicator that I've kind of tracked over this, and unfortunately I didn't really set a goal of improvement here. I should have. I wasn't thinking that through a year ago, but percent of worsening stage 2 to 4 pressure ulcers is the high indicator that we were kind of looking at that tells us our success of an improved outcome for residents. And we've improved our results on that by 37% year over year. So I think it's highly successful. Now, this is just one component of the BPG. We're still tweaking and working on other pieces of it, but this one piece, we think we did a pretty good job. So we thought we'd share that. Yep, so that's everything. I've just put one little references to where I got my Lean information from. And my contact information is there as well. And I'll stop there and ask if there's any questions. Sorry, talk fast.
No, thank you very much, Tolleen, for that excellent presentation and for really being able to bridge the gap between the theory and the Lean process and its application when it comes to reducing pressure injuries ultimately by doing appropriate and timely assessments. So thank you. We do have 3 questions in the chat box. And so Julia is asking, who is responsible for updating and maintaining these boards?
Yeah, so the nurses actually, so the nurses manage that whole process themselves. Like on each RHA. So, and as it comes up that's what has to happen. So if today they do their weekly assessment, for example, they complete that, they move the sticky to the den box, and then they'll do a sticky on next week's board for the same day for next week. Let's do again the next week. If it's resolved and we don't have to do another assessment, then of course they wouldn't have to put that sticky up for the next week.
Okay, excellent. Lily is asking, can you please explain one more time why changes can't be made directly on the TAR? Example, change the TAR setting to remain as a pop-up through various shifts until the task is completed.
Yeah, and I don't think that's something that's out of the realm of possibility at all. I think that makes sense. But certainly we found with the issues that we were having, that having this process visible to all staff, right from the night staff coming on, know that what's happening tomorrow or the rest of today was really helpful. So just making it visual to everyone for the whole week can see what's coming up. Versus sort of that more in the moment on your shift as it's popping up on the TAR. And they're not at the computer the whole shift either. So this just helped keep it more visual. Certainly, I wouldn't say that system wouldn't work for some organizations, absolutely. But this we found is what helped us solve our problem.
Okay, excellent, thank you. And there's another question here. On the Kanban board, the stickies have the name of the assessment on it. Did it also have the resident name or just the assessment?
Yeah, so the sticky themselves, and again, you can set up your boards any way that makes sense for the process that you're trying to make visible. So what we did, and if you actually get the slide, you'll be able to make it larger and you'll be able to see it. But you'll be able to make the image bigger so you can actually see what's written on those things. So what we did was we color coded them. So down at the bottom is a legend. So the legend is yellow stickies are weekly assessments. Pink stickies, for example, are admissions. Yeah, so down at the bottom is a legend. And that just says weekly assessments on the yellow. The pink one, it says admissions. The blue one says LOAs, and the green one says hospital admissions, readmissions. So that's just our legend. So that tells us what our color coding is. Just like with the traffic light, red is always stop. We know that. So yellow in this scenario is always weekly assessments. And then what's written on those yellow stickies, like under, that would be Thursday, I think. So under Thursday is the name of the resident. Sometimes they write what skin issue that they're assessing. So are they assessing, a coccyx, are they assessing a heel? They might write that piece down, but they need to look at the resident's plan of care to really know for sure all the details that they need to look at. But the yellow sticky just has their name. So I have names of celebrities on there. So like Marilyn Monroe is what's written down there, but that's the name of the resident. So hope that helps.
Okay, thank you very much. I think that's really helpful, and it seems like it's a great communication tool, and very visual and sort of a point of care prompt. So there's many sort of advantages it seems to be with regard to being able to improve the timeliness of the assessments and to be able to plan ahead of time as a interprofessional team.
Yeah, it did really work for us. As I said to whoever asked the other question, absolutely, it may not work for others, and there might be other more electronic means of solving the problem. We tried a number of things and nothing had sort of worked, and this was the final thing we went to, and it worked. So I'm keeping on with it.
Mm-hmm. Okay, so that's good to know that it seemed like there was an evaluation process in regard to tracking the other strategies that you've done and still not hitting the benchmark that you were aiming for, or you and your staff were aiming for. So then this strategy, and I think you said you had reached 100% with this one.
Yeah, immediately. As soon as we put the boards in place, we were at 100% immediately.
Wow.
I never saw any strategy in my whole career ever work that well so quickly.
Yeah, that's very impressive. It obviously works for the staff.
Yeah, it works for the staff. And I think that's key too, right? As I said with Lean, it is about going to the people who have to do the work, right? So if this wouldn't work for them, I mean, me pushing them and pushing is still not going to maybe solve the problem, right?
Mm-hmm.
But it worked for them. And so we're keeping on kind of thing.
Yeah, well, that's excellent. And just in follow-up to that, Sumangala is asking, what other solutions were you looking into before you tried the Kanban board?
Well, I would say that it was a lot of traditional things, so the whole auditing process and reminding people, and absolutely looking at, what's the right process in the TARS, and, using the TARS to, and I'm not clinical on the floor, so I don't know the right terms for what buttons they push in the TARS to make it continue to show up for people, but using those reminder systems in the TARS to say, yep, this isn't done, remind, so we don't forget. But we were still forgetting and still not getting it done, and we would learn that when we audited retroactively. And that's what was also very distressing, was when you're auditing, the error has already happened. Mm-hmm. Right? We're auditing later. I mean, you can still audit in the moment, of course, but it's harder to do in that MARS system. You have to watch for those greens and yellows and all that. Harder for the DOC to sort of be on top of that. So when we're doing that retrospective audit, we would learn, oh, we still didn't get that done on time, or we still were a day late with that, or whatever. So using the TARS, we tried all different kinds of strategies, with reminding staff. And it's not anybody's fault. This is not a blame issue at all. We just clearly had an issue with a process that we needed to find another way. And that's another thing about Lean. It is about processes, not people. So, certainly it wasn't working for us, for our team, for whatever reason. And so tried something different. And so this way, honestly, the DOC, when she's making her rounds, she can see those stickies moving to that done box, and we're auditing in the moment. The clinical care coordinator can walk by and know in the moment whether we're on time without even logging into the computer to do that, without very little effort from anybody. And the staff can see it. In the next shift coming on, she can see immediately, oh, there was 2 assessments didn't get done today. Yep, that's right. And they can talk about it at shift change and make sure it happens. So, but certainly not the only methodology, for sure. But I just share it that it worked for us.
Yes, exactly. And hence the, as you were saying, the importance of really knowing what the root cause of the issue is, and then the importance of evaluation and that feedback in regard to the strategies that you've implemented.
Yep.
Okay, so there is about 5 more minutes, and if anyone else has any questions, please feel free to write in the chat box. I did receive a few questions on my end here. So Tolleen, what education did the staff need to implement this process?
Yeah, so I did, again, similar to what I did here with this team was just a very high level understanding of what Kanban is and sort of what the purpose of that process is. I think people do need to be taught a little bit about that, that we're not just randomly throwing boards on the wall and here, put these stickies around, that there is a method to the madness. I think that's really key. So I did do sort of a Lean 101, 20 minutes with staff, registered staff, about what that means and what the goal was. So we did that through our registered staff meetings, and through an email document that outlined very clearly all the steps. But the steps look really, what's the word I'm looking for? A lot. It looks like a lot when you write it all down, but when you talk about it, it doesn't look anywhere near as complicated, right? So we just educated the staff, and they seem to get it pretty quickly and implement it.
Wow. Well, obviously so, with 100% success rate. And so I'm thinking, and this is the second question that was asked, how did the nurses respond to this change?
Yeah, I think so. Initially, I think, as with anything, it was like, really, we're going to do this. You know what I mean?
Yeah.
But they knew we had to fix it for sure, and it's a compliance issue. And it was. I didn't say that in the presentation. I think I forgot, but it was a compliance issue for us as well. That we needed to address it for sure. And so while it might have been a little bit skeptical, I think when they started working with it and they saw how quick it was and how collaborative it was, as I said, a year and a bit later, they're still doing it with, how things don't always, you introduce something and it falls apart, 3 months later, 15 months later, they're still doing it. And I don't have to go in and say, oh, where's your stickies on the board? I don't see it, I don't have to do that. They do it. So I think they've embraced it.
Yes.
Yeah.
Oh, excellent. And just to reiterate the education that you provided to the staff in terms of this process, Sumangala was saying, I'm so glad you took the time to explain the process and philosophy and Kanban to the staff. She had a similar board implemented on her unit, but there was no background information or education. So she said it was nice to hear that.
Oh, I appreciate that. And I think it's so important that people understand the purpose behind something. They don't need to have 2 years education about it, but they certainly need to have some high level and really what is meaningful to them, right? And I think that's where we have to start with, is what is meaningful to that employee and what would be helpful for them and how it's going to make their life better, right?
Yeah. Exactly. The what's in
and
it.
I think they did find that value pretty quickly. Yeah.
Oh, excellent. Excellent. Well, the great success there. And, thank you very much again for sharing your expertise in this area. Very much appreciated. And just to let everyone know, that is contact information of Tolleen's is on the screen, and a PDF version of this slide deck is going to be shared with all of the participants, and she is willing also to share her email address in case anyone has any questions. So just wanted to let you know that to please fill out the evaluation survey so that we continue to provide you with relevant topics and speakers that resonate with you as champions and other healthcare professionals and providers who want to be able to initiate and to be able to implement change in their own workplace settings. And if you have any other questions, please contact Andrea. She is the project lead for the Champions program at astubbs@rnao.ca. So thank you very much, everyone, and have a great afternoon. And thank you, Tolleen, again for joining us.
Thank you very much for inviting me. It was a pleasure. Thank you.
You're welcome.